Thank you so much. Thank you for the invitation to tell you about our MLD research here in Amsterdam. I just try to share my screen. Yes, should work.
Yes,
you should see it now. Good.
We can. Thank you so much.
Well, thank you. So those are my disclosures regarding MLD. I'm consulting without a personal compensation for Orchard and Shire Takeda, and we are taking part in the Embolden study. I'm working in the Amsterdam Leukodystrophy Center, and that center was founded about 20 years ago by Mayo van der Knaap. First of all, we leaned a lot on MRI analysis and definition of new leukodystrophies, identification of the causal genes. And now it's shifted to understanding disease mechanisms. We do that using mouse models, but also patient tissue of patients donating their brains after they've passed away. We are doing natural history studies and take part in treatment trials, also have set up own treatment trials. So that's a very broad approach to leukodystrophies, and I'm very glad that I'm able to work in a big team comprising also a lot of very bright young people doing research on those disorders. And you see here Shanice, who is doing a PhD project on neuropathy and metachromatic leukodystrophy, and Murtada, who is doing quantitative MRI in metachromatic leukodystrophy. So metachromatic leukodystrophy has been one of the main research domains of our center since 2008. And we do research on treatment outcome, general management, neuropathy, mechanisms of treatment, biomarkers. And a year ago, we started to set up a disease registry. And that's only possible in close collaboration with other groups and also with the families and patients. So metachromatic leukodystrophy is one of the old leukodystrophies like adrenoleukodystrophy. It's been first described more than 100 years ago by Alzheimer. It's a lysosomal storage disorder where you lack that enzyme, aryl sulfatase A or ASA, which actually cuts the sulfatide group from this long fatty chain. And that leads to accumulation of sulfatides, especially in cell membranes. And those cell membranes are very abundant in the brain and also in the peripheral nerves. And that's why you get first symptoms in those organs. You can diagnose the disease by clinical presentation and the typical MRI abnormalities, enzyme activity in leukocytes, the mutation analysis, and also sulfatide excretion in urine. And here you see those sulfatide-laden cells, which are very pink in that staining and look as they are about to burst. There are where almost any age of onset is possible. We call the earliest form the late infantile form, and those children usually present about 18 months of age. Then we have the early and late juvenile forms and the adult form. And in general, an early onset means motor symptoms and a rapid progression, and late onset means more cognitive symptoms and insidious progression, although you can also have a late onset with a relatively quick progression. And it depends a bit on the residual activity of aryl sulfatase A. If you have a little bit of activity left, you have a later onset than the children without any enzyme activity. It affects also other organs like the gallbladder, for example. And that's important for the daily management of patients. In many countries, the early onset form, the late infantile form, is the most frequent one. In the Netherlands, we have juvenile patients, which are in the majority. We see about 4 to 5 patients per year here. So you see it's a rare disease, but among leukodystrophies, it's perhaps even the most common leukodystrophy. That's the typical MRI. When you compare it with this normal MRI, this high signal, this almost white signal with those dots or stripes in the white matter, and the most typical MRI abnormalities you see usually in the young children, in the juvenile patients. In adults, the MRI abnormalities may be less typical at presentation. So you may have more diagnostic uncertainty. There are some treatment options for the disease. The one we know for the longest time is hematopoietic stem cell transplantation, or HCST, and there's also ex vivo gene therapy, which also uses this hematopoietic stem cell transplantation approach, but then with patients' genetically corrected stem cells, whereas this approach uses donor hematopoietic stem cells. And then there's a study ongoing where you replace the missing enzyme directly into the cerebrospinal fluid. And not every patient, unfortunately, is eligible for treatment, because if the disease is too far advanced, the treatment just doesn't work anymore and can even accelerate deterioration in those patients. And whether or not a patient is eligible for treatment depends on age and form of metachromatic leukodystrophy, presence or absence of symptoms, and of course availability, because gene therapy is not yet generally available. So what's the available evidence for those treatments? For HCST, we know that it's effective when performed before the onset of symptoms in children older than 4 years. The evidence for younger children is scarce. It may stabilize the disease when performed early after disease onset, certainly in late juvenile and adult patients, although that's also not so well researched. And it doesn't have a significant influence on the pre-existing neuropathy, which means that this is still going on after treatment. I mentioned that already. It may trigger fast deterioration when performed too late. It has a significant morbidity and also mortality, because what you do is you treat a patient with MLD with a very strong chemotherapy, which destroys the patient's bone marrow. And then you rescue the patient with donor hematopoietic stem cells, which are either taken from cord blood or bone marrow of a donor. Those cells are transplanted. They first go to the bone marrow, and from the bone marrow, they actually go to the entire body and the brain, where they produce and secrete the missing enzyme. The long-term, and that treatment, that chemotherapy treatment, and the fact that you get donor cells from perhaps a brother or a sister or an unrelated donor makes that you're at risk for infections, for graft versus host disease, and so on. So you need quite some care and medication. And it's a treatment which keeps you weeks, sometimes months at the hospital. The very long-term outcome is still unclear. I think we are all a bit concerned about the fact that the leukodystrophy, so the white matter abnormalities, seem very well controlled if you treat patients early enough. But we wonder, what about long-term consequences of this treatment? The gene therapy is working a bit differently than the hematopoietic stem cell transplantation. The stem cells are taken from the patient, transduced with lentivirus, which includes the normal ARSA gene. And then the patient is also treated with a strong chemotherapy, after that, the genetically corrected cells are transplanted, and then they again go to the bone marrow, and from the bone marrow migrate into the brain. With the gene therapy, actually, we do a little bit of a squeak, so that those cells produce more arousal-fatase A than normally healthy people do, which has theoretically some advantages, because it's thought that they can clear the accumulated sulfatides faster. That treatment is not effective when the disease is too far advanced, and we don't know good data about a very long-term outcome because the treatment is not available so long. But side effects like immune suppression are much, much better than in the allogenic hematopoietic stem cell transplantation, because you don't have the risk of a graft versus host disease, because you transplant the own bone marrow and not the bone marrow from a donor. And when you compare, and those are the Italian data, compare this untreated child at age 40 months with this treated SIP at the same age, you see that the MRI here is almost normal. And also when you look at MRI scores, motor scores, IQ, and a crude motor score for MLD, you see that patients are more or less developing normally and have a normal, more or less normal MRI with only mild abnormalities. But you also see patients who are treated already with the symptoms and MRI abnormalities have actually a clinical course which resembles patients without treatment. There's a study on intrathecal enzyme replacement. You can't give the enzyme into the blood because the blood-brain barrier prevents the enzyme from moving into the brain tissue. So what can be done is that you give the enzyme into the cerebrospinal fluid, where it then can enter the brain tissue. And a small trial, pilot trial has been done, and there was a tendency to slower deterioration in the cohort, in the group of patients who received the highest dose in this trial. And the metabolic marker more or less normalized in all groups, although that didn't went along with disease stabilization in most of those patients. The patients with slower deterioration had a higher motor function at start, which also indicates that there seems to be a point of no return in that disease where probably no treatment will work for patients. And the device which allows us to give the enzyme weekly into the cerebrospinal fluid has a relatively high complication rate, which means, again, an operation to resolve that. So our challenges are, first of all, of course, we would like to improve those treatments, but we also need to decide whether a patient who has already developed symptoms is still eligible for a treatment. Or otherwise, when is the disease too far advanced to be treated any longer? And this is a difficult question because we see patients who are still able to walk and talk, but are too much advanced for treatment. And that's not, of course, what we would like to see. But you see that in patients with the early onset forms, you have a relatively steep decline from disease onset until the fact that you need to walk only with support. And also relatively fast to a time where you don't have any motor function left. And with the patients with later onset, that is much less predictable. And you see some stabilization even without treatment. And the same is true with the swallowing function, and the same is also true for language. So you have patients who have a cognitive onset, which means they don't have any motor signs sometimes, even at careful neurological examination, when they have developed already some dementia. And those patients actually have a stable motor function really even for decades. And I think we all know those patients. So it's in those patients, you can't take motor function as an outcome parameter. And they have also language decline, but also slower than the other patients. And you see that is much more pronounced than the motor symptoms in this special group. So what do we do to see whether a treatment is still on time? IQ at diagnosis is very important. Neurological examination, a patient should certainly be able to walk without support. We score the MRI abnormalities of the brain with a semi-quantitative description. We also look at levels of certain metabolites with brain mode proton spectroscopy directly in the brain. And recently we have explored the use of biomarkers. You heard that in the last talk, also a neurofilament light chain, which might help with that. So with the spectroscopy, we can measure concentration of certain metabolites in the brain, and you see that NAA, which is a marker for the neuronal function. And in that patient, it's very, very low. It should be even higher than this in a normal white matter. And you see that patient with MLD, also in the affected white matter, has a much higher NAA than this one. And when we look at predictability, patients with a normal or almost normal NAA compared to controls, they have a relatively good or moderate outcome 6 or 12 months after diagnosis. And patients with a low NAA have a poor outcome invariably. And this, for example, is a patient who was able at that MRI still to walk and to talk. So that helps us in decision-making in this difficult patient group. And we looked also at the neurofilament light levels, and we also see a clear difference between patients who have already symptoms and patients who are still pre-symptomatic, although also in pre-symptomatic patients, it can be quite elevated and indicates that the disease will start within a short time. So how does transplantation work in the brain? Because we see that MRI abnormalities can even improve. This is a patient, she's now 5 years after that MRI, so in a short, in 1 or 2 months, she will get another MRI scan to see how it looks like. But you see that 4.5 years after her transplantation, the white matter abnormalities here have almost disappeared. And that family donated the brain of their daughter who died after a neurologically successful transplantation about 4 years later. It's not that child. And you see that the white matter in her looks more or less normal. And that's an untransplanted child of a similar age. So the idea was that the transplanted donor cells went into the brain and produced the enzyme in the brain. And this enzyme should be taken up by all kinds of brain cells, the neurons, but also the myelin-producing cells in the brain. And that's what we call cross-correction. What we saw in our studies, where we had 3 children available after they died after transplantation, we saw that indeed the donor cells come into the brain, they produce the enzyme, and they digest the sulfatides. And there is also new myelin formed. You can see that because the new myelin is thinner than the normal myelin sheath in healthy persons. What we also saw that there is a quite high inflammatory reaction. But what we didn't see is a cross correction. So we couldn't see the enzyme, the erythropoiesis A, in brain cells like neurons or glial cells. And colleagues did similar experiments and studies in a mouse model for Krabbe disease, which is also a lysosomal white matter disease, and they found more or less the same. And what we also saw is that the enzyme after transplantation is really good to see in the white matter where the leukodystrophy is going on. Here it's an untransplanted patient and you don't see anything, any brown spots, but it's almost not visible in the gray matter, so in the brain cortex where all your neurons are. And that's something which is a bit concerning. We also can't see it in neurons themselves. Because for a good long-term outcome, also the gray matter should be targeted because neurons also store sulfatides. So what we think now is that the transplantation works in MLD by having the enzyme in the brain, and the enzyme and the macrophages are able to digest all this accumulated sulfatide and can actually process the oligodendrocytes dying from the sulfatide accumulation. And that allows oligodendrocyte progenitors to develop and to produce new myelin. So a little bit different than we originally thought. In animal models, there was also were also trials with enzyme replacement, and there was also this what we see in our patients when started later. There is a kind of a point of no return when the disease, any treatment doesn't work anymore. And another thing which is important is enzyme produced by macrophages, which are the cells which are transplanted or genetically corrected, is actually not effectively taken up by brain cells. And the oligodendrocytes do not easily take up erythropoiesis A anyway. So this is something we should keep in mind when we think of treatments and treatment improvement in metachromatic leukodystrophy. There are other challenges. What about late juvenile or adult patients with a cognitive presentation without significant motor involvement? How do we define treatment success? Of course, we would like to have a complete cure, but I'm not sure, even with the earliest treatment, whether children will be completely cured. How about long-term outcome? Do our patients develop a gray matter disease because the transplantation and the gene therapy don't target the gray matter? So those are important questions to ask because we all want to improve outcome of the treated patients. About 2/3 of our patients at diagnosis are too advanced for transplantation to be successful. And those children we also need to treat because they can develop all kinds of complications. And what we do now, we start early, certainly in children, where we know they will develop a significant spasticity within years after diagnosis. we start intrathecal Baclofen treatment early on, so they get a pump implanted, which can bring the medication, the antispasticity medication Baclofen, directly into the cerebrospinal fluid. What we also do, because most children do have gallbladder abnormalities with a thick gallbladder, with the polyps in the gallbladder, and we usually take the gallbladder out with a laparoscopic operation at the same time as we insert a gastrostomy, which is one operation. Otherwise, in adults, we do cholecystectomy when there are gallbladder abnormalities at ultrasound. Otherwise, we check that regularly. We treat spasticity also with intrathecal Baclofen when indicated, and give a gastrostomy when indicated. And with this more active management, I think quality of life has improved, although it's still a severe disease, and patients, of course, unfortunately, keep deteriorating. So what have we learned in the last 13 or 14 years? Treatments have to be performed early. The gene therapy is very promising, has less morbidity, certainly, and is probably a bit more effective than allogeneic stem cell transplantation. We have now markers helping to decide whether or not it's too late for transplantation, IQ, the NAA at spectroscopy, and probably also neurofilament light chain. The bone marrow cells do migrate to the brain and do produce aerosulfatase A there, but there is no cross-correction of brain cells. Transplanted bone marrow cells have an anti-inflammatory neuroprotective effect. I think that's clear as well. And we have remyelination, so improvement of the myelin in the brain after transplantation when we do it early enough. And we do think, and that's something to address, gray matter is not sufficiently targeted by transplantation approaches. So how to improve the current situation? I think we need independent, so pharma-independent international disease registries, which include treated patients, and that means patients treated with different kind of treatments to be able to compare. We, of course, all hope for neonatal screening, which does come with its own challenges because it's in some cases still difficult to predict when a disease will start, which means difficult to time a treatment procedure. We need to improve the enzyme entry into affected tissues and cells, and we need accepted criteria for treatment decisions because we don't want treatments which are sure not to help anymore. That's something we should work together on it. And we also would like to coordinate trial planning and design better, also regarding inclusion criteria for patients. And to address some of those questions, we actually started an international Mld registry actually focused on Europe, and Daphne Schoenmakers, our PhD student, is responsible for that. And we have specialists, transplantation specialists, child neurologists, metabolic physicians from many countries in Europe, including the UK, which are participating in the Mld initiative. And our goal is to register the European patients, also to compare treatment effects. Also, for example, when gene therapy is on the market, to follow those patients uniformly and see how treatment outcome is. So this is the team, or not all people, but most people of the Mld team. And those are our most important collaborators from Tübingen and from New York. And you see here the 3 PhD students I already pointed out, but also a rehabilitation physician, MRI physicist, neuropathologist, geneticist, someone actually specializing in expensive treatments and how expensive should a treatment be for rare disease. An adult metabolic physician. So you see that many people are needed to treat this complex disease. So thank you very much for your attention. And I'm not sure whether I have to answer questions now. Thank you.